My name is Jeff Van Treese. I am the president of MARR, the Michigan Association of Recovery Residences. I'd like to thank everybody for being here this afternoon. And we've got Dr. Best from England, who's trying to adapt the RECCAP instrument, which he's the primary author of, to use at recovery community organizations and recovery community centers. And so with that, I will leave it to Dr. Bess and Jessica to present this afternoon on all things RECCAP related.
Hi, Jeff, and firstly, can we both say we're delighted to be here and we're really pleased to meet all of you. It's been a really interesting week so far in Michigan, and we have one more trip to Ann Arbor tomorrow. What we're going to do, the basic format of what we're going to do is I'm going to do a 5-10 minute background on where the RECCAP came from. We're then going to do a demo. I'll make a few concluding comments, and then we'll throw it open for comments, questions. And the big thing for us really is, how do we make it work for you most effectively? So really that's what we're trying to do. It probably makes it a little bit easier, Jeff, and I hope you're okay with this, if people just very quickly go around and say who they are and who they work for, so we've got a sense of who we're presenting to.
Absolutely. Why don't we start with Donna?
Hi, good afternoon, everyone. My name is Donna Simmons, Pastor Donna Simmons. I live in Battle Creek, Michigan, and I work with Gracious Homes here in Battle Creek, Michigan. It's a shelter for women that are recovering from addictions, and we help and aid them with getting back on their feet.
Thanks, Donna.
You're welcome.
Mark, you want to give a brief intro? Mark Kilgore.
Yeah, hi everyone. I'm Mark Kilgore. I work for CARE Southeastern Michigan's Recovery United Community Center, and I'm a person in long-term recovery.
Thanks, Mark. Annie?
My name is Ann King Hudson. I'm with Recovery Advocates in Livingston County, which is actually Brighton, Michigan, and we have a recovery house plus an RCO. Glad to have you here today.
Thank you.
Excellent. Tracy Madden.
Hi, everybody. My name is Tracy Madden. I am a person in long-term recovery, and I work for an amazing organization called Peer 360 Recovery Alliance. Happy to be here.
Glad to have you here. Ricardo?
Ricardo Bowden. I also work with 360 Recovery Alliance, recovery community organization in and around Saginaw Bay region. I'm also a person in long-term sustained recovery.
Thank you.
Nicholas Alexander.
Good afternoon, everybody. I'm Nick. I'm a person grateful to be in long-term recovery, and I also work for Peer 360 Recovery Alliance, and I'm out here in the shop.
Thanks, Nick. Eddie?
Hello, everyone. I also am a person in long-term recovery, work with Detroit Recovery Project, which is a certified community behavioral health clinic located right here in Detroit, Michigan. Thank you.
Pleased to meet you.
And then I've got somebody on the left-hand side that I can't see their name, but it ends with MBO.
Oh, I think you're talking about myself. I'm Kyle Rambo. I'm the CEO for Catholic Social Services of the Upper Peninsula. We service the entire UP. In terms of recovery supports, we have 3 recovery houses, 2 for men, 1 for women, and we also have an established MAID program out of one of our outpatient clinics here. And then we have a very robust child welfare team that services all the counties of the UP.
Excellent. Yeah, I blame my computer. I just went right over your name. I could just see your face, but glad to have you here. Krista?
Good afternoon. I'm Krista Gaylor from 1016 Recovery Network, and I'm the Chief Program Officer. And we have 2 recovery homes, and I've got some staff on here also. So I'm happy to be here.
Excellent,
Thank you.
thanks. Jessica? Jessica Van Horn, yeah.
Sorry, I couldn't unmute myself. I'm Jessica Van Horn. I am the Community Engagement Manager for 1016 in Midland County. So we have 2 recovery houses here in Midland that I help oversee.
Thank you.
And the next person is unnamed, but is Every Woman's Place is what is showing up.
My name is Erin, and I am the program supervisor, sober living program supervisor here at Every Woman's Place. And we're located in Muskegon, Michigan.
Oh, great.
Thank you.
Lisa? Lisa Young?
Hi there, I'm Lisa Young with Paula's House in Monroe, Michigan. I'm the operations manager, and we are recovery residents for women, and they can have their minor children here with them. Happy to be here.
Excellent. Marnie?
Hi, everyone. I'm Marnie Winfield. I work with Addiction Treatment Services Agency. I'm the recovery homes manager. Right now we have 7 recovery homes, 5 men and 2 women, with a total of right now 58 clients. So happy to be here.
Thanks, Marnie. Eric?
Hey, I'm Eric.
I think Eric might have some technical difficulties.
I'll just mention that Eric works for me. He works for Catholic Social Services, the Upper Peninsula, and he's overall responsible for both the men's houses.
Excellent, thanks. Grayson?
Is that Grayson or Miss Grace?
Grayson Lewis.
Oh, no, that's not me. There's Grace.
Hi, I'm Grayson Lewis with NIMSAS Recovery Center. We provide peer support for 21 counties in the lower northern part of Michigan.
Thank you.
David at Recovery Institute.
Hi, everybody. Yes, I'm David Harris. I'm with Recovery Institute of Southwest Michigan here in Kalamazoo. We incorporate peer support and recovery coaching. I am the new community outreach liaison for our organization. So nice to be here. Good to meet all of you.
Excellent.
Thank you.
And Jill?
I'm the executive director of Bayview Drop-In Center in Alpena and also president of Alpena Recovery Alliance.
Thanks, Joe. I think it's the first time we've met, but you're a Facebook friend of mine, right? And then Ms. Grace.
Yes, good afternoon, everyone. Happy to be here, being part of a team. I am the founder and executive director of Gracious Homes, Inc. in Battle Creek, Michigan. And I have some support individuals on here with me as well. We're fortunate to be able to be a part of the recovery residency. We're expanding in from transitional housing to a recovery home. So I've got a lot of support from individuals already that have been up and running. So for those of you who have supported us in this journey, we thank you and we're glad to be a part of the team.
Excellent.
Thank you.
Sarah Matthews. Sarah? Going once, going twice. We'll save you for last, Sarah. Kelley, would you like to introduce yourself? Kelley Darin.
Absolutely. Hi, everyone. My name is Kelley Darin. A lot of familiar faces on here. I am the project coordinator for the RECCAP program for the state of Michigan. So I look forward to working with each and every one of you.
Thanks, Kelley. Wally? You got to unmute yourself, Wally. While Wally works on that, Brenda? Brenda Max.
Good morning, or I'm sorry, good afternoon. Max with Live Right Structure Recovery Corp. We also have recovery homes, 7 of them in the Macomb area. We have a resource center in Roseville. And Sarah is actually with us as well, but she was on a phone call. So she's with Live Right as well. Thank you so much.
Thank you. Patrick?
Hey, Jeff. Good afternoon, everybody. Patrick Patterson with BW Rock, the Blue Water Recovery and Outreach Center and RCO in Port Huron, Michigan, and I'm a person in long-term recovery. Thanks for having me.
Thanks, Patrick. Brian? Brian K. Tara Laugh from Boise. I'm sorry.
You did all right. Hi, I'm Tara LaFramboise from 1016 Recovery Network. I am the Recovery Housing Coordinator in Midland, Michigan.
Great. Kayla, you want to introduce yourself? Can't hear you.
Our mic isn't working.
That's not working. So if anybody has not had an opportunity to introduce yourself, please unmute yourself and say hi. Otherwise, that's my list of people. Oh. Jill.
Hi.
Yeah.
Oh, can you hear me?
Yep.
Hi, my name is Crystal with A Mother's Touch, located in Grand Rapids, Michigan. I am the founder and executive director. We provide women specialized recovery residents with the women have a minor child up to the age of 5.
Excellent. Thanks,
Thank
Crystal.
you for having me. Yep.
And Jill Busha and Heather Miller has her hand up. But you got to unmute yourself.
I'm sorry, guys. I am here. I am in a conference with somebody, and I was just informed that you guys were calling my name. I do apologize. This is Sarah Matthews from Live Right.
Okay, thanks, Sarah. So having said that, I think we've all either introduced ourselves or attempted to introduce ourselves. So I'll give it back to you, David.
Perfect. So I'll ask Jessica to introduce herself, then I'll introduce myself.
So this will be very quick. Hi, everyone. I'm Jessica Castile from the Recovery Outcomes Institute. I'm the Director of Operations, and I will support Kelly as your point of contact in this project.
Okay, so and basically between us, we are responsible for the origins and the development of the RECCAP, the science and the implementation of it, and crucially, its application in online settings. So I'm just going to give you a quick 5-minute history of why and where it all comes from. Then we're just going to do a tour. So we'll take 20 minutes or so to do a tour. I'll wrap up at the end of that, and then we'll throw it over to you for comments, questions, and crucially, from our point of view, what next. So let me tell you a little bit about my own background and position. So basically, I hold 4 different positions. So I'm the professor and director of the Centre for Addiction Recovery Research at Leeds Trinity University in England. I'm president of the Recovery Outcomes Institute in Florida. And I've got 2 other academic roles. So I'm an honorary professor in the School of Regulation and Global Governance at the Australian National University in Canberra. And I'm an honorary associate professor in Eastern Health Clinical School at Monash University in Melbourne in Australia. So I've got a range of academic backgrounds. Anyway, I've worked in the addictions field for a number of years, and I worked in acute clinical services. I did my training at a place called the Institute of Psychiatry in London. And we ran a number of methadone programs, community drug and alcohol treatment, inpatient detox, and residential rehab services in South London. And in the time I was there, we only ever really appeared to see 2 lots of people. People who either never left our services or people who are in a revolving door in and out of our services. And our model was a fundamentally kind of flawed model. What we did was we basically mapped out all the pathologies, illnesses, and deficits people had, and we tried to patch them over and cover it up and address those pathologies. Now, there's nothing wrong with that as an approach, but it's not about wellness. And increasingly, I got interested in the idea of not focusing so much on that acute front end part, but on the things that allow people to make significant sustainable changes to their lives in the long term. And it's a big philosophical change, switching from a pathology model to a strengths model. So essentially what that means is people stop being patients and they become partners in their own recovery. We switch from focusing on deficits to focusing on strengths. It's a much more social model. And the idea is that recovery doesn't happen in a specialist clinic. It happens in the community, in people's lived environments. And as I'm sure you're all aware, about 10 or 15 years ago, there was the beginnings of a significant transition to a recovery movement in the addictions field worldwide. But one of the things that was a traditional challenge was generally people would say it's personal, it's subjective, it's individual, it changes over time, all of which is true, none of which helps us with a science of recovery. And there were two American academics called Robert Granfield and William Cloud, first used the term recovery capital in 1998. And over the next 10 years, it gained a bit of traction as an idea, as a concept. But it was really 2008, 2009, before people started seeing that it offered a genuine possibility for two things. One, something we could count and measure, and secondly, something we could change. We could offer clear support and guidance to help build this. So effectively, my work in the last 12 years or so has largely focused on the development of the science of recovery capital. So I'd done a big study in Glasgow and Birmingham in 2008, 2009, where we identified two big things that mattered to people in recovery. One was the more time you spent with other people in recovery. And the second was the more stuff you actually did. The more meaningful activities you engaged in, the better you did. And we refer to this as the Goya study, and Goya, not very scientifically, stands for get off your arse. The more you do, the better you'll do. And spending time with other people in recovery helps with that. And subsequently, we've shown exactly the same effects with recovery residences in Florida. And then in 2011, 2012, I partnered up with a very eminent recovery researcher called William White and a statistician called Teodora Grushkova. And we developed two different measures. The first of them was called the Recovery Group Participation Scale that started trying to measure community capital. And then the Assessment of Recovery Capital in 2012, which measured personal recovery capital and social recovery capital. And they were both fine. They were both useful, primarily research measures. But the problems were twofold. One, nobody really knew what the results meant. And secondly, nobody knew what to do with them. So over the course of the last 5-6 years, I've been working closely with the Recovery Outcomes Institute in Florida to try and create a model that does two things. One, it will measure where somebody is at with their recovery capital, primarily what strengths they have. But it's not just a measurement tool. And one of the big changes for us was to what we call the MPE model. And that means the measurement part is really just the start, because that should inform recovery care planning, which should then inform active engagement in community activities and resources. So this is an action model. This is a model for change, not just a way of counting things. So what we're going to do now is we're going to go through a case example. So we're going to share our screen, and Jessica will take us into the ARMS system. The ARMS system, which is where we would record each individual case. And just while we're getting this set up, what I'd want to say about this is it's important to say that the two things about the rec cap. Firstly, it can be completed in any setting. So it can be completed on a telephone, an iPad, a laptop, any of these things. Secondly, there is no assumption that the recovery coach or the recovery navigator, to use our language, has any specific qualifications or expertise. And indeed, in our work with this in the first recovery prison in the UK, HMP Home House, peer prisoners were actually better navigators than were prison officers at doing this. So what we're going to do is we're going to run you through a fictitious case, and hopefully you would recognize the fact that Wile E. Coyote is not a real person. So we're going to just quickly show you the evaluation, which is the measure, so you get a sense of what the measure looks like. And we'll deliberately go through this quite quickly, because for those of you who'll be involved, there is a much more detailed training to come. So what we start by collecting is some very basic demographic characteristics: name, gender, age. And then we go straight from that to measuring 5 things about well-being. We measure on a ruler scale from a 0 to 20. We measure psychological health, physical health, quality of life, quality of accommodation, and support network. And you'll see that poor old Wiley isn't doing well in accommodation, but he's doing well. He's doing reasonably in some of the other things. So we then go into the 2 negative sections that we measure. Negative recovery capital are barriers to recovery and unmet needs. And there are 5 acute barriers that the science would say to us, you have to try and do something about before you can start creating sustainable strength. So they are accommodation, where we ask about the risk of eviction, acute housing problems, where people have lived for the last 3 months, and whether they've got any difficulties in securing housing because of debt issues. So that's number 1. Number 2 is substance use. And it's an online collapsible questionnaire. So if the person here says, no, they haven't used any legal or illegal substances in the last 90 days, it would simply skip that whole section and move forward with it. But unfortunately for us, in our case example, Wiley does report substance use. So we then go down, and what we ask is, has this substance ever been a problem? If has the person used it in the last 90 days? And if the answer to that is yes, it will then ask about the frequency of use in the last 90 days. One of the reasons for our trip to Michigan is to adapt the list of substances potentially to things that are more directly relevant for you. And you can imagine that as we go into different countries, so different substances have greater importance. So in the UK prison system, you might have just noticed NPS synthetics. Well, that's novel psychoactive substances like spice and mamba, but they may not apply in Michigan, so we can take them out. The third area is risk-taking, and this is basically a short number of questions that focus primarily on HIV and hepatitis C risk of bloodborne viruses from injecting practices. The 4th type of barrier is involvement in the justice system. So we ask people about their offending and about their active involvement. So currently we're piloting in 2 drug courts in the United States, one in Rhode Island, one in Boston. Well, obviously for us, it doesn't make sense to ask them, are you involved in the justice system? Because the very fact they're in a drug court means they're involved in the justice system. So again, we would adapt that. The last barrier is a reversal, and I mentioned this right at the start. What we're looking at here is lack of any meaningful activities. So we basically ask, are you involved in any kind of meaningful activities or not? So that's our 5 barriers. The second, if you like, debit side of the ledger is about whether the person has any unmet service needs. So across 8 different kinds of professional services, drug treatment, alcohol treatment, mental health, housing, employment, relationships, and primary health care and other specialist needs, we ask 3 questions potentially. Do you currently access help? If you do, are you happy with it? And whether you do get that service or not, do you need additional support in that area? And the do they need additional support is the unmet need that then carries forward into our score profile. So that's all of the negatives. We now start measuring the strengths people have in the recovery journey. And that really, we measure 3 different types of what we know the science tells us are key aspects of recovery capital. personal recovery capital, which is measured with 25 questions, and we'll explain how they chunk up when we look at the scoring. And basically, they are all just tick boxes. So essentially, the idea is, do you have a sense of purpose in life? It's important for your recovery journey. If the answer to that is yes, you tick it. If you're not sure, or the answer is sometimes, you skip it. So it's things you unequivocally agree with, and there's 25 of them that split into 5 subdomains. And we'll say a little bit more when we get further down to the scoring about what we do with that. So once the person's addressed them, the second half of the assessment of recovery capital is social recovery capital. 25 questions again splits into 5 subdomains that focuses on social well-being. And the theoretical model is the aim is to build personal recovery capital, but you do it partly by social recovery capital and partly by accessing resources in the community. So the third area that we look at is recovery group participation. And this is community capital. It starts with our standard measure, which is 14 items, exactly the same thing. People endorse them if they're the case. And in the published work we've done recently, the extent of recovery group participation was a good predictor, both of who stayed in recovery residences and who showed growth in recovery capital in recovery residences. Now, for peer support, we also asked, do you need additional support from any of the following: peer support, 12-step mutual aid, other community recovery groups, or online groups? The next section is a 4-item questionnaire that measures specifically social identity and social support. And then we move forward from that on to the next section, which is our measure of motivation. This comes from a scale from Kelley and Green called the Commitment to Sobriety Scale. Person answers on their motivation. And then that's at the end of our standard questions. The last set of questions are the recognition of the fact that people do have personal subjective experiences and needs. So we ask people where they see themselves, what are their current goals, what do they need to help them achieve their goals, and what support, who do they rely on for support in their recovery journey. And the idea here is we've gathered what the science tells us matters to predict recovery. Now we ask about your own specific personal objectives and goals in that process. And that brings us to the end of the survey. So one of the things we'll standardly be asked is, how long does it take to fill in? And the answer that I'm going to give you, which may not be very popular, is the longer the better. Because ideally, if the client is literate and doesn't have neurocognitive challenges and they do it on their own, and certainly once they've done it 2 or 3 times previously, it should take about 20 to 25 minutes to fill in. But the first time they do it, when they sit with a navigator or a recovery coach, we'd want it to take longer because we'd be wanting you to ask questions and use the completion of this, particularly about strengths, to build a relationship and build an alliance with them. Now, Jessica has shown this on a case example, but it's important to say from our point of view that you should be aware of the fact that the moment the client hits the submit button, this is what appears. So the results are instant. And it's one of the reasons, certainly, why the first time the recovery coach or navigator should be there just to talk people through what it means. And the scales, the total score ranges from -100 to +100. And the composite of them, which is where Jessica's highlighted, is the total recovery capital index, which for Wiley Coyote is -15.9. And what that basically means is they have more deficits and barriers than they currently have strengths. Now, what we've tried to do is to make it visually easy and acceptable. So what we've got is a traffic lighted system. So for each of the sections we've just completed, there is it's either green, which means things are good, amber, which means things are okay, or red, which there's a problem. So you'll see as we scroll down to the barriers, 4 out of 5 for Wiley Coyote are a barrier. So these are things we would suggest you have to address before you move on to building strengths. And the next part of this moving down is that we've got unmet service needs. And again, those in red are those that are barriers to moving forward. Now, as we move further down, we have the assessment of recovery capital. And I mentioned that that splits into 2 lots of 5 subdomains. And so the 5 for personal recovery capital are coping, physical health, psychological health, recovery experiences, and risk. And the 5 for social recovery capital are citizenship, housing and safety, meaningful activities, social support, and substance use and sobriety. Now, we try and not give too much information here, but we'll just give you an example with housing and safety. So we know that Wiley's not done well. And what we have, so you can click on that and you can actually look at what specific questions he answered yes or no to. And you can see for Wiley, the only thing that he feels is good about his housing is he feels personal freedom regarding shaping his own destiny, but he doesn't feel safe in his living environment. He doesn't feel his living space has helped him to encourage his recovery journey. He's not proud of his home, and he doesn't feel free of threat or harm at home. And what we've shown you here is that for him, that was his first completion, but then the other parts of that were the second, third, and fourth time he filled that in. Now, on the right-hand side, and because I'm Scottish and obsessed with donuts, the other 3 strengths are measured with donuts. So we have the same thing for community recovery capital, social support, and for commitment to sobriety. You have the same system of traffic lights. And again, you can dig into those and look at the specific items to say both how did the individual answer the questions and how did that change over time. So we try not to give too much information at the start, but you can dig down to the individual question level if you want to. And essentially, what we have done here is basically to show you the initial profiling of the results. Now, because I'm not so keen on this part, and Jessica loves the analogy of the trees, I'm going to let her explain what the trees mean here.
So here is the beginning of the transition to working out the plan and the goals that are going to be owned by the member, as part of their recovery plan. So this is what we refer to as our discovery map that takes those results and just displays them differently as a talking point for the navigator and for the client. So the top of this, you can see that this is our orchid. This is our apple orchid. And on some of those trees, we have green, healthy looking apples that are ready. And we have amber apples and red apples that need a little bit of help to grow green. So if we want all of our strengths, which are these trees here, personal capital, social community capital, commitment, and where's my 5th one? I have to move the camera. And quality of life to really grow and flourish, we need to address the soil that the trees are growing in. So down here, we have all of the barriers and the unmet service needs that popped up as a result of how this person, answered that questionnaire. So we know that we need to address these right now in order for those trees to grow, bright and strong. So if we were to choose 5 of these today, which areas are the most important that we need to address to start working out goals and drilling down into those is how we would start to work through this recovery plan. So it's just the pivot.
Yeah, and it's really important to say that's part of the reason why the coach or the navigator has to be there, because they will negotiate that with the client there and then, with the resident there and then, to say, right, what are we starting with? How are we going to address this? And as I said before, one of the key things for us about designing the RECCAP was it is not just a questionnaire. It leads to systematic, evidence-based recovery interventions and support. So the first part of that is recovery care planning. And the second part of that is how we engage effectively in communities. And beyond the first completion, and we'll show you some of the change scores in a second, but beyond the initial completion, every time you do a RECCAP review, essentially what you're doing is looking backwards to see what goals have been met and looking forwards to revise and reset the goals. Now, very early this morning, I was doing this presentation to people from the Scottish Government. And one of the things that they were really keen to point out was saying, well, people's goals change over time. Well, absolutely. And what we try and do is then to say, well, how have we progressed towards the goals? And how do we need to refine our goals, both in terms of what you have achieved and learned and what has changed in your world that you need to do? So we don't make particular goals mandatory because They are down to what you decide in discussion with your clients. But what we do offer is a model to say, here are some templated goals that we potentially would suggest. And Jessica will just quickly talk you through how this works. So when you complete the RECCAP, you get that score profile, and then we try and support the process of moving forward to say, and what next?
So in this section, when we go through how to configure the application with each of you, we would create a templated goal, templates that we can use, your navigators can use to really easily drill down and make some modifications for use when they're actually meeting with people. So if they sat down and they said, I want to address housing, I want to address, my mental health care, I really need to get in because I'm out of my meds. So I know that that's an issue for me. I need to address this other specialist that I was looking for that came out of, the assessment. I have an impacted tooth. I need to get to a dentist, or I'm going to go out and find something that's going to get rid of this pain because I know how to solve that problem. So we're going to pick those 5 things that we want to focus on for right now. We're just going to select them. We can add them to the recovery plan. And then when we come to the recovery plan, we can look at that template. And let's say I want to go to this one, other specialist service. This is the dentist that we need to, go and address. So I need to find somebody because I don't have healthcare. I don't know how I'm going to pay for this. These are the tasks. So this is a goal that Wiley sat down with his recovery navigator and mapped out. This is the milestone. Here's the start date. Here's the due date. And these are the things that we're going to do together. So I'm going to help you with scheduling this appointment. We're going to confirm that this is something that you're eligible to receive. So you don't have to worry about, being able to pay for it. Are there any resources? Is this a local county health center that you can go to that they'll provide this service for? And we're going to get this taken care of together. So we're partners in this journey. And once you're done with these tasks, you're going to update this, but we can then, share that successful completion.
And for us, one of the big things about this is it's a management system as well. So effectively what the ARMS system allows you to do is to review as you go through before you come to that review point, what's going on. And we can set this up so that you get reminders to say, the person's not achieved all their goals, they're working towards them and where they go. The other thing that's worth mentioning at this stage is access. We have a hierarchical model for access. So if I was Jessica's client, I can access my own data on my phone. I can't edit it, but I can look at it. And if I'm doing well and I want to show my mum or my employer I'm progressing in my recovery journey, I can allow them access to it as well. Jessica will have access to me, Wiley, and all her other clients. But if it turns out that Jeff is Jessica's boss, then Jeff has access to all of Jessica's clients and all of the other workers' clients in that organization. And Kelley, as your local enterprise champion or coordinator for Michigan, she would get to see all of the providers. So we create this access hierarchically. And in our work, we use in places like Michigan and in Virginia, we'll be using this primarily as a model for supporting clients to improve their recovery outcomes and recovery pathways. So it's essentially at client level it operates, but the system operates at 3 different levels. So it has that client level as a model of measurement and intervention. It has a kind of performance management intermediate level where you can use it to meet the development needs of workers and organizations by saying, here are the areas you struggle in. And Jessica and I are also doing some work in Maryland, and there its primary focus is as an outcome monitoring tool. So that kind of concludes the demonstration. What I'm just going to do is spend a couple of minutes just reviewing where we are up to with the system. So over the course of the last year or two, we now have virtually 19,000 completed RECCAPs. And why is that important? Well, it's important for 2 reasons. The first is it proves that it can be done. And we know that there can be challenges. There can be challenges around integrating with other measures, around time and availability, around staffing processes and training. And I'll get Jessica to say something about the training approach in a minute. But the second thing it allows us to do is creating norms. So we can start mapping out for a 35-year-old white male, this is the pathway and the trajectory we'd expect them to show changes in over time. And for us, this is primarily about helping people improve their recovery outcomes. But one of the things we've started being able to do is to start to say, well, how does it affect, how can we learn things scientifically and generalizably from this? So we've just published a paper last week based on data in Florida, where we used this to say who is more or less likely to be retained in recovery residences and what kind of clients are going to show the greatest growth in recovery residences. And that model we're now developing in a second lot of data analysis in Virginia. So part of what we're doing is attempting to evidence that what you do works. It helps people to build recovery capital. But it's also a developmental process that's around you understanding your own organization's pathways and processes more effectively. Now, do you want to say a little bit about the training that sits behind it and the kind of infrastructure?
Mm-hmm. And also just a touch point on some of the hierarchy that you mentioned earlier as well. When he said that the enterprise level champions like Kelley's and Jeff's of the world at MARR, they do have access to drill down into provider information. They can never see client information. So they don't get any of the identifiable information for any of your clients. They can see things like growth and recovery capital for the program as a whole, demographics. They can see some of the areas where they might be able to go to funding sources, you know, through the state, through your PHIP providers, through any of the other funding sources and local grants, and say, this is the information we have. Here are the areas that we need additional support and funding in, and we can show that, you know, this is what works and what we need to really focus on. So just to clarify that as well. And as far as training and support, so Kelley is your first point of contact. We're all very happy with Kelley. So for those of you who have worked with her so far, I hope that you all agree so far. I'm very happy with Kelley. So she's been going through this. I do support Kelley through this process. So Kelley is being trained as she is training you. So she is helping with the onboarding process. She will go through these trainings with you. I will help her with those trainings. You have a full support desk, and we are going to be releasing an LMS shortly. So a learning management system where you and your staff can log in any time of the day, 24/7, to log in and complete these trainings as well. So we're very excited about that.
Perfect. So, and just to conclude with where we're up to and what we're doing in Michigan at the moment. So, as I said, we've about 19,000 completed RECCAP forms. The vast majority of them are from the US, and the vast majority of them are from recovery residences. We do have some services in the UK and New Zealand that we're working with and partnering up with, and that includes some recovery community organizations, therapeutic communities, and residential rehabs. However, one of the things that we are now trying to do is to develop a specific version that works for RCOs, and we're really grateful to Jeff for the opportunity to come here and start meeting with some of you and having the opportunity to start refining this work so that we can create a specific version that works most effectively in RCOs, really for us to be able to demonstrate and to work out the processes through which RCOs lead to improvements in recovery capital. So this is a really exciting opportunity for us. That's everything, I think. Is there anything else you wanted to present?
No, I want lots of time for them to there's now 28 of you and there's 2 of us. We want to be able to answer any questions that you might have and get some feedback.
Perfect. So Jeff, back over to you to convene any kind of questions and answers. And look, the other part of this I'd want to hear a bit more about is what you would need from us to make this work and to make this effective for you.
Sure. Thanks, David. So just a 10,000-foot view, all the recovery residences in Michigan that are MARR certified have RECCAP already available to you. All the recovery community organizations and the recovery community centers, that's the new bit of funding that the state of Michigan has blessed MARR with to offer RECCAP to every RCO or RCC in Michigan free of charge. And this is the initial part of that work is David and Jessica are trying to adapt and modify the existing RECCAP instrument for best use in a recovery community center or a recovery community organization. So with that, I'm going to open up the floor for any questions.
Jeff, this is Kyle. I was wondering if you could if you could help us or review for us the implementation timeline for the system.
So Kelly, go ahead.
So essentially what it looks like, it can take up to 2 months. The process starts with, I have sent to all operators an email just introducing myself and a brief introduction. If you have already been on this call, then we don't necessarily need to do a Zoom. What I generally do is have a Zoom with each individual operator just to give a high level view, just like we did today. So you have something to base questions on, somewhere to start, some basic understanding. After we go through that, we go through a process of sending what we call the welcome email. And this asks for information about your organization. We don't tell you with this system, you need to change and use this form. We ask you what forms you use and build those forms in your system for you. So essentially we ask for your bed boards, any documentation that you use, your housing, any kind of users, etc. That requires information being returned to us. The more quickly that we can get that information returned, the more quickly the process can move. So essentially, as soon as we get that information back, I would build out your application. After that, we meet again. That can take a couple of days, just kind of depending on what your documentation looks like, any adaptations that we need to make it work for your program. After that, we would meet with you again to review the applications for you to say, yes, this looks like it'll work. Yes, no, maybe we need to tweak this a little bit. Give you some brief information. We go through like some of the information that's input into the application for you. That takes about an hour. And then there's 3 additional trainings after that. So after that initial review of your application, we would move on into a little bit more in-depth training. And that it generally takes about an hour and a half each time. And like Jessica mentioned, we are moving into having the online system. So that will make it more convenient for time-wise. But generally speaking, I make myself available when you are available. As best as possible, because we realize that you have a lot going on and we want to make it as easy as possible for you. So it can take up to 2 months. It all kind of depends on just how quickly we get information back. And like I said, everyone that's certified in the state of Michigan should have received already a welcome email from myself, just identifying, introducing myself and also giving you a brief overview from Dr. Best that we have on our website regarding what RECCAP and basic information. So give or take 2 months, it could be less if we get the information back more quickly, but that's kind of a benchmark of what we look at for onboarding process.
Thank you, Kelly. And just to clarify too, so some of the things that she's referring to, we did the demo for the measure, plan, engage process that's built into the system, but the system is meant to be a management system as well. So right now it's really geared towards recovery residences. What we're doing is modifying that for RCOs as well. So if you don't have a bed board, obviously we're not building a bed board. If you have intake packets or intake forms that you usually have your clients fill out, we know that our system may not have those questions. You all have different questions depending on your funding sources and data that you need to collect. So Kelly gets that from you and then she builds that stuff into the system. Then we'll go through the training on how to utilize the management aspects of the system first, so you can get your clients in, we can get your staff in. We'll go through what roles and responsibilities your staff members each have, and then we'll identify who needs to be in which trainings so that you can use those systems. So it's not everybody in the same training every time, just for clarity's sake. The other thing, and I think that Kelly can agree, is I know it sounds like 60 days is a long time, but really the bulk of that time is us just trying to get information from you. So the faster we get that survey filled out, the faster we can get you on board and utilizing the system.
I have a question. Will we have to get additional training for the RCO, or will that be the same process? Or will this training then serve also for the RCO?
It'll serve for the RCO as well.
Well, one of the things we want to do, Anne, is basically to have that discussion with you. So if you pop your email into the chat, and any RCOs want to pop their emails into the chats, one of the things we want to do is to find out, do we need to tweak in any way what the training and support might be for RCOs. So if you're willing to support us and help us in that process, and that applies to Anna and to any of the rest of you, please do put your emails into the chat and we'll get back to you as we move forward with this process.
I got a question. How compatible will the system be? So say like down here in Detroit, we use our funded source is DWIN, and they have their own system. A lot of times they have you do say biopsychosocials and those type of assessments in their system, and then they're required on our side. Is it a way you can make that system where we don't have to duplicate these documents, that it will pull from that system?
It's tricky, and we're trying to work with a lot of these funding sources because we know that they have their own requirements. So if they're mandating that you're using their own, platform for GIPRA requirements, that sort of thing, then you're still going to continue to have to use those until we get them, to agree to this. We are meeting with them. We're going through that phase. We met with the state and with MARR, this week while we've been here. So we're hoping to escalate some of those discussions as well. There is some opportunity for building in APIs so that one system can talk to the others. So we'll just pull data, back and forth. It really depends on the platform. So it's something that I have to look at and get my software engineers on the phone to say, is this something that we can do? And we'd have to talk to the owner of that other software platform. So as long as everybody's in agreement, that is an opportunity. The easiest thing for us to do is to go back to those funding sources and to say, take a look at what we have. Will this meet all of your requirements? Because we can build custom reports and dashboards into this as part of that process. So if there's data elements that they're looking for, it can be automatic.
And we have managed it before. I mean, with the courts that we work with in Boston and Rhode Island, we had a lot of work to do to get our data systems compatible with their data systems. So it can be a bit of work, but it's definitely achievable. So it's a great question. We're not going to pull the wool over your eyes and say it's easy or there's a magical fix and everything works out really quickly, but it's a platform where we can certainly embed other things relatively easily. And from our point of view, it's not a problem. And we've had lots of experience of effectively importing other instruments and measures and then reporting them back as part of the process. So it really is about permissions from your partners and your funders, not about whether the system can manage it.
And we've worked through that in Virginia as well. So we do understand that challenge.
I would ask a question, maybe even offer a statement. First of all, I know all RCOs are not the same. Our organization is a very decentralized, very spontaneous. We don't enroll people in anything. We're very spontaneous out in the community. As I listen to this presentation, I don't see how this would match how we do our work. We would have to change our entire work processes to meet this deal. So I'm trying to understand what's the headwinds about this that I need to be thoughtful about or not. It just, our organization, we have really been very, very careful to create a very more social engagement kind of a world, as opposed to that more formalized kind of processes that this speaks to.
Thank you, Ricardo. And it's a great point. And actually, the service we went to yesterday, Rise Recovery in Lansing, they have a hybrid model. So they both have what you're describing as a very low threshold drop-in recovery support service, and they have a formal structured registration where there's like an assessment and a discharge. If you only have drop-ins, the last thing we would want to do is to change your processes. We're not involved, we're not trying to change anyone's philosophies. So it would seem to me, Ricardo, that if that's all you do and nobody formally registers or signs up or has any kind of ongoing relationship with a recovery coach or a recovery navigator, sadly, I don't think this model's appropriate for you, and it just wouldn't apply. And one of the reasons we're here is, I think Jessica and I both had the nervousness and concern that that might apply to all of the recovery residences. You know, not all of you only effectively run drop-ins. That's clearly not the case. I think it's possibly worth having a separate discussion outside this about, are there ways it might be useful? Should we think about possible alternatives? But my view would be, it doesn't make sense if there's not some kind of ongoing named relationship with the individual. So if you operate only on a very low threshold drop-in basis with like social activities and whatever else, then I can't really see how this would work. And I'm conscious to some extent that's kind of Jeff's decision, not mine. But I'm with you in saying we're not trying to turn services from one thing into another.
But it would be very useful to still have your information if you have an events calendar or anything, because one huge part of the system, Ricardo, is about resources that are in the area. So when he said recovery residences a moment ago, he meant recovery, centers and organizations, not recovery residences. But since all of the housing, in the area, and we're bringing on the centers, we're trying to create links. So all of those houses may need to know about, what's going on in your area, and maybe they don't. So you could be a resource that we could link, events and meaningful engagement for people in that area. So you still have a big part to play in this.
Okay, thank you.
Excellent. So look, I'm absolutely delighted that 5 different people have got in touch with us about potentially engaging a little bit further. So we will be in touch with all of you as part of that process. Jeff, Kelly, anything else that you wanted to cover off here? And please, that we will also put our email addresses into the chat so that you can get in touch with us if there's anything you want from either of us. But I'll pass it back to Jeff and Kelly to see if there's any further questions that we should be trying to address just now.
I don't have anything in addition to what we've already talked about, David. I'd like to thank everybody that's taken an hour out of their afternoons to be with us today. It's very helpful in the process of trying to do the design. And let me also say, for everybody that's volunteered to put their name in the chat to talk about how you run things at your recovery community organization or recovery community center, that's going to be critical. That's very important for in the process of designing the system so that it seamlessly fits in with what you're doing. So having said that, I don't have anything else unless anybody else has another question. Or Kelly, you'd like to add something?
No, I don't have anything specific to add. I'll just put my email address in the chat as well. So if anyone has a reason that they feel they need to get a hold of me as well, it'll be there and available for you.
Yeah.
Thank you for your time.
Thank you, everyone. It was really nice to meet you.
Thank you.
Thanks, guys.
And hopefully we'll meet you all again soon. Thank you very much.
Thank you.
Thank you.
Bye now.
Bye-bye.